Good afternoon from the Montreal Heart Institute. My name is Anita Asgar. I'm joined by Dr. Serge Doucet. We're here to show you a live case. So if we could just go to our slides. So our case today is a complex left main PCI post-CABG. It's an 82-year-old male presenting with shortness of breath and a non-STEMI. He's got a previous history of rheumatic mitral stenosis with a mechanical mitral valve replacement in 1992, ischemic heart disease, and at the same time had bypass surgery with a lima to the LAD and a vein graft to the PDA. He had an acute coronary syndrome last year, 2022, treated medically. And at the time, his coronary angiography showed a left main of 50% and included circumflex and both a lima and a vein graft that were patent. He's also known for hypertension, dyslipidemia. He's got left ventricular dysfunction with an ejection fraction of 40 to 45%, moderate tricuspid regurgitation, and moderate aortic stenosis and atrial fibrillation. So he presented this time with increasing dyspnea for the past 4 weeks, as well as new onset chest pain with ST elevation in V1 and V2. So he was transferred from an outside hospital to our institution. When he arrived, his ST segments had normalized and his chest pain had improved, but he did have an elevated troponin and he was diagnosed with a non-STEMI, and we repeated his coronary angiography, which we'll show you in a couple of minutes. So just to summarize what the angiography is going to show, we have progression of left main disease with now a lesion of 70 to 80%. It's a very calcified lesion. We have a long first diagonal branch with a 90-degree angulation and a small septal, but the rest of the angiogram is unchanged from 2022. He also underwent additional testing since he's been hospitalized, which shows, as we mentioned, an ejection fraction of 40 to 45%, a mechanical mitral valve replacement with a mean gradient of 5, moderate to severe tricuspid regurgitation, and moderate AS with a mean gradient of 19. So in terms of things to think about and points to consider, Serge and I will talk to you about this, but, what is the indication for revascularization? What is the optimal revascularization strategy? Is it PCI or is it redo CABG? And now that we have some moderate valve disease, do we do an AVR? Do we do a tricuspid annuloplasty? What is the impact of the comorbidities? And when all is said and done, what's the optimal antiplatelet therapy? So we did calculate his risk score for a redo AVR and CABG in the presence of a mechanical mitral valve. And as you can see, his STS risk of mortality was over 12%, morbidity or mortality almost 43%. So in terms of our procedural considerations, what type of vascular access are we going to use? I'm going to let Serge talk to you about this at the end here, but what guide catheter, what choice of PCI wire, how are we going to modify the lesion if needed? Is it rotational atherectomy, intravascular lithotripsy? Are we going to use intravascular imaging for stent sizing, and what's our antiplatelet therapy? So maybe, Serge, you can talk a little bit about your procedural plan, then we'll look at the angiography.
Yeah, you will see the film in a couple of seconds, I would say. But with the information we have now, what we want to do is to go through the lesion, the left main and the proximal LAD, which are very calcified, to open the segment for the very large diagonal branch. Because the diagonal is a 90 degrees angle, we think we cannot go through. So we'll put the wire in the septal branch and then use a very small burr, 1.25, 1.5, and use imaging facilities if we need, probably at the end, and then we'll decide for stent and antiplatelet therapy. Is it the last slide?
Next slide. Yeah, so things potentially we're going to discuss during this case. So what is the optimal management of patients with previous CABG? And you're going to see our approach to a PCI of a calcified lesion. Hopefully we'll get to use some intravascular imaging. And at the very end, we'll talk to you about, our thoughts for antiplatelet. So maybe we can go straight to the coronary angiogram that was performed.
Donc, l'angio dans fin de semaine. So I was on call during the last weekend, and this patient came, I think it was on Saturday morning from another hospital. So we We've looked at all the angiogram. Like Anita said, he presented with ST elevation, but when he arrived in our hospital, the ST were down and with only 1 on 10 pain. So that's the left main in the LAD. You can see that there's very tight lesion. There's 50-60% lesion on the left main proximal LAD, but a very tight lesion suivante just before a very large diagonal branch. That's the spider view. You see the 90 degrees angle of the diagonal, and I think there's a very small part of LAD past the diagonal and then a septal branch. And you can see that there's a tight lesion at the septal branch. We don't want to open this tight lesion, but we know that our wire will have to go through. So that's why we use in a hydrophilic wire, we use a BMW 2, and you'll see maybe you can see les prochaines. So we'll look at the Lima, l'autre après, which is still good like last year, and which you see the LAD coming up until the very proximal part just after the diagonal. So the rest of the LAD is well perfused with the Lima. Next. Okay, next. So that's next. Okay, next. And then we'll see the other graph. Wait, was it? So that's the graph on the right, which is okay with small disease. Y en a-tu d'autres après? Okay. And collateral to the circumflex. So all this, and there's the akinesia is on the inferior wall with the 40 to 45% adjacent fraction. So on peut montrer nos shots so we just do a couple of shots this afternoon. So I'm 7 French to get more support with a long introducer, extra backup 3.5, 7 French, like I said, and I use a BMW 2. Okay, next. So you see the very tight lesion just before the diagonal branch. You see the tight lesion on the septal branch. So next. And with this angle, we think that with the tight lesion just before the diagonal and the 90 degrees angle, we cannot go in the diagonal with the wire. It would be very difficult. And the rotablator cannot do this 90 degrees angle. So we prefer to go straight in the septal branch, do rotablator, put the stent, if we can, just after the diagonal and hope that the diagonal will stay open, no disease, 90 degrees angle. Next. And that's a lateral view just to see that it's really a septal branch that we're looking at, very large, but a septal branch, and you see the diagonal branch. Anita, you?
Yeah, just to summarize, I mean, it's a really interesting case. This is a gentleman who comes in with a non-STEMI. He does have moderate valve disease, and the discussion was no need to really treat the valve disease now and to really focus on the presenting illness, which is this non-STEMI. As very well explained. We want to preserve flow and improve flow to that diagonal branch. And to do so, we're going to treat the left main proximal LAD, but not actually stent into the diagonal, but stent in front of it. Not a lot of disease in the ostium, so the hope is there won't be anything in the way of plaque shift into the ostium of the diagonal.
So that's the BMW 2, which I try to pass the very tight lesion. La prochaine. So I went through and I stuck in the lesion of the septal branch. It was more difficult to go through, but I was able to go further. So next, like this, laisse-la jouer.
La cité, c'est quoi?
So then we decide to choose a microcatheter, which is a turnpike. So we'll put the turnpike and try to cross this tight lesion to be able to place the rota wire, which for sure would not have go through. But with the microcatheter, we could probably put the rota wire down the septal branch. Next. So we push, that's the turnpike, which just cross the very tight lesion and the septal, and that's the BMW, which I will retrieve. Next. So that's the rotor wire, prochaine. And that's the rotor wire, which is down the septal branch. Okay. So we're ready to go through with the Rotor Pro. We use the smaller burr 1.25. We think that we can probably do the job with 1.25, 1.5. If we need 1.75, then we have the 7th wrench, which will be easier to go through. Okay, we'll go. La CT, t'es correct?
On n'a pas encore. On est en train de répéter.
Okay, so just to be sure, a test to...
Peux-tu juste centrer, s'il te plaît? C'est bon.
Okay, so you see the burr, which is in the guider. So we're ready to go. And we'll run at 180,000 RPM.
Tu veux le dire?
Ouais, je vais la pousser un petit peu.
OK.
Bon, on va commencer. Commencer là pour rentrer. Okay, I think we'll start there. We're just in. You can see the guider, it's there. We can go out. Okay.
Ouais, vas-y.
Tu regardes 180 000, s'il te plaît, Justin? Il bloque. Bonne pression. So there was a small bradycardia. Pressure is still good. So it was, I went through the first part of left main in proximal AD, but not in the distal lesion, which is the tight lesion. But we go not more than 30 seconds. We want to be sure that the burr is really working on all the different lesions. So I'll go with another pass. And I just go through. I block. Ça va, Monsieur Gosselin? OK. Vous dormez? OK.
Je pense qu'il t'en a faim, donc.
Oui,
il n'est pas en train de. Il ralentisse un peu.
Ouais. Okay, so I think that with the last pass, I went through the tight lesion. What we can look, okay, I'll do a last pass with the 1.25. You see, it's easier to go in. No more resistance. Okay. Just to be sure that we have flow, we'll do a small test. Flow is good. Okay, so I think we need the 1.5, so we have to do the exchange. Just m'ouvrir there. Copy. OK. Out?
Oui.
Tu peux tirer un peu, c'est pas grave.
OK.
Okay, so the wire is maybe a little deep in the septal. We can pull back a little bit.
S'il te plaît.
Ouais.
Enlever ça.
Correct. It's a septal branch, so there's less risk. We're in the myocardium, so for perforation, we don't want, but it's septal branch is, I would say, less risky. Ça va? On va faire un shot.
OK, c'est né.
Ouais, je peux tirer encore un petit peu le guide.
Okay, just
OK, on va prendre la 1.5. Bon, veux-tu aller de ce côté-là?
Ouais.
Okay, so we'll change the burr. I don't know if there's any comment coming from.
You have any comments, George?
No? Okay. So what about other technique to go through that calcium? We don't think that the shockwave would be able to go through. We think that really the rotoblader is with the 1.25 is the technology can go through that kind of very calcified, very long lesion. And we couldn't have tried with NC balloon, high pressure balloon, but I think that because of the length of the calcium, it's better to go with that kind of preparation with the atherectomy.
Il faut que je vois, par exemple.
What about what else to do? If we had we could not cross the tight lesion in the septal punch, we can have used another wire. My choice was a more powerful wire, like what I was thinking, maybe a Pilot 150 or something like that, which can go through. And the filter also, like we use in CTO.
Just like guide.
So we're changing. If the 1.5 go through, I think we can probably go with balloon afterwards. L'ACT control est correct. So the patient, like we said, is on Plavix, heparin for sure. He was on heparin since he stopped his warfarin on Saturday. We're planning, if we're successful, to discuss what kind of antiplatelet therapy we would go with. It's probably aspirin only for the in-hospital phase of the hospitalization. And then Plavix and warfarin. So 1.25, 1.5.
Attention avec ça, s'il te plaît. Okay, we're coming with the 1.5 burr.
So you need to test the burr before you enter the patient, for sure.
A little bend in your wire. Okay.
Ouais. Okay. On va le pousser un peu. Est-ce que ça sort? Tu peux me faire la... 20 secondes.
Il faut que ça sorte un peu plus. OK.
OK. Fait que là, on n'est plus Dynaglide.
Dynaglide est
correct. OK. Fait qu'on va juste le tester.
OK.
180 000. 180,000 RPM. OK, laisse-le là. C'est bon. Good.
Off.
Okay, so we'll make the exchange.
Montre-moi plus de gaining, s'il te plaît. Ça t'a. Perfect.
So I go slowly, and Anita is holding the wire. So in case of spasm after a rotoblader, we can use verapamil, nitrate. But because the first pass were okay, and we go progressively with a bigger burr, it should be okay. So the burr is coming. Opérer. Tire un petit peu sur le guide. Okay, burr is coming.
Feels far from the femoral.
Okay, so. Okay, so when you're in the band, in the catheter even, you can feel that
Montre-moi
it...
plus tes gainings,
Ouais.
s'il te plaît. Pousse la table. Parfait.
OK, puis là, peut-être tirer un petit peu le guide pour que je
Ouais,
gagne.
juste ça.
Tu peux tirer. Sinon,
Il faut que je vois le guide, s'il te plaît. Parce que je suis un peu trop loin. OK.
Tu peux tirer encore un peu le guide. J'ai plus de facilité à l'amener. Ah, OK.
Un peu que je vois le guide.
Ouais, tu peux tirer encore un petit peu le guide. Ça va faciliter, ça va enlever le slack.
Ça me bloque. OK.
Bon.
Ça, c'est le max. J'ai une genre de résistance. Là.
Okay, so the wire is stuck. Oh. Ouais.
Faut que j'ouvre.
Ouais, je sais pas trop.
Okay.
Ouais, peut-être.
Open here.
Okay, we can go with the run. Maybe easier to to pull back the wire. OK, fait que tu fais juste ouvrir. Ouais.
OK. Right.
OK.
OK. Open.
$180. OK. Ouais. OK. OK. On va essayer de reculer un peu. Dynaglide. OK, voilà. C'est ce qu'il fallait faire. OK. Okay, so I went on Dynaglide and I pulled back the roller, the burr, and I was able to pull back the wire. We just need to see that. On va faire un petit test.
Mm-hmm.
Okay, so it's okay. On va filmer. We'll film to be sure that there's no perforation.
Okay, silly.
Okay. Looks okay. Okay, so then we'll go with our burr again. The wire is in a more safe position.
Advance.
Oh, okay. Ah, okay, I just went through. Ouais, je suis d'accord. OK. OK, je vais pousser le wire un peu. Okay. I just want to pull back the... Juste tirer sur le... Es-tu capable de le retirer, le rotant? Attention au guide, attention au guide. Je ne suis pas capable. OK, laisse-le là. OK.
Okay. The wires advance a little bit.
Ouais. OK, so the wire is here. OK, là, on va... Tiens, je vais juste prendre ta place.
Oui.
Essayer de... So I'll try to pull back a little bit. Burr. Juste pousse le guide un peu si t'es capable. Non?
No.
OK. OK, so we'll try to... Peut-être essayer de pousser encore le guide si t'es capable.
Okay,
So
we'll try to advance the wire a little bit more.
Okay, je vais le mettre avec le Dynaglide, c'est mieux. Vas-y.
No.
Okay.
Oh.
Okay, I'll do it. Okay. Okay, so it was stuck in the lesion, like you saw. On va juste faire un petit test pour voir où est-ce qu'on est.
Ouais.
Okay, still good. So we can try to go with this wire, but it will be difficult for sure.
Let me try to advance.
Ouais.
Okay.
It's going in.
All right, it doesn't. Very hard to steer.
Faudrait que tu aies un torqueur. Tu vas regarder le mettre
Un
vers
torqueur qu'on peut utiliser?
Ouais, faut que tu enlèves ça. Puis tu mets. Okay, so we'll go with the torqueur. So I think that the 1.5 went through the first part, maybe not the very last lesion. We had trouble because it was stuck. So it means that it's a very tight lesion, very calcified. The wire also was a little distal, but we were able to put it back. So then we'll try to reposition the wire. That's the yes. Tu peux faire un test, s'il te plaît, Bianca? Probablement la diagonale. Are we in the diagonal branch?
Are you
Test?
open?
Okay, excuse. Test. No, it's the LED.
Okay, Floro, you're on.
Avec le burr dans la... Patient has no pain. I know that the burr is in the proximal LED or the distal left main. Difficult to move the wire. Okay, so what we can do, I think I will pull back. C'était comme ça, okay. In there. I need to pull back. Okay, like this. Okay. 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 So now are you, is it easier to manipulate the?
Yeah.
You can advance, but there's no way you can really.
Torqueability is not, you know.
It's a rotablator wire.
Actually, you can feel the friction in the lesion when I try to turn the wire.
It's not. Okay, so. It's not moving.
No, it's not.
Okay, so we'll. I think we'll pull back the rotablator, and we'll see what is the result. And then we may push the wire more distal and use again the rotablator. We'll see what we can do, but so Dynaglide. Okay, so on this. Okay, so Scapi. Oh.
Okay, we're out.
All right.
I'm not out yet. Sorry, can't see. We're almost out. Go ahead. Continue.
You see?
No, now I'm out.
Okay. Okay. Okay, donc on va enlever ça.
Prends-toi une serviette, s'il te plaît, Bianca.
Une serviette. OK.
Oui, je pense qu'il est prise sur le guide. Hein?
Ouais.
Merci.
Okay. No, we'll see. Okay. OK. So, on va voir où est-ce qu'on est. Si le guide est complètement sorti.
Il est sorti dans la galerie.
Ouais. OK.
Yeah.
OK. So we'll film.
Okay, so we'll do cine. So in this case, would you prefer to rewire and rerotor, or would you prefer to take another wire, like our BMW 2, rewire the lesion and see?
Yeah. So yeah, and then the discussion is, do the first burr and the halfway of second burr have done the job, and we will be able to go with balloon. But I prefer to go with the BMW wire. So on va prendre le BMW. Et on va enlever celui-là.
Okay, so we've taken out the rotor wire. We're going to take a BMW 2 and rewire the lesion.
Avec le turnpike, ouais. Essayer de garder ça. So turnpike again. So it can happen. The burr can be stuck in the lesion. The 1.25 was not stuck. 1.5 was stuck. It means that it's a very tight and calcified lesion. Je suis avancé. So, hop, wire, OK, c'est bon. Avance encore. OK. Je vais pousser, OK. So the wire is a little bend is different. Tu peux me faire des petits tests, Bianca? Yeah. I need to go up. Yes.
And now we're in that little septal lesion that was quite tight, trying to get through.
Voilà un petit test, Bianca. Ouais, that's the lesion.
It looks promising.
Ouais, je pense que je suis dans la paroi, peut-être. Ah. Test. Ouais, ouf.
Ouais, il faut être vers le haut.
Okay. We know that this one could be the more difficult to went through. I was able first, but then
I'm going to bring the turnpike behind you a bit.
Yeah.
So if you want to fix, I'm going to advance the turnpike a little bit. Try to give you a bit more support.
And go, yeah. Can
You want me to
continue.
come a little bit more? Okay.
Oh, yeah.
I'm going to come a little closer. Just give you some support there. across that lesion. Oh, gotcha.
Okay. Okay.
Looks like you're going back to the same branch.
Yeah.
Just give us a
Fais
test.
un petit test, Bianca.
Perfect.
Yeah. Okay. So you can push the turnpike.
Yeah. Advance the turnpike over.
So you see the wire it was difficult for the wire to go through that lesion, but the turnpike is going in.
Relatively easily, to be honest.
Yeah.
A little bit of buckling there.
Okay, so.
Okay, I'll leave it there.
Attention juste au guiding,
Ouais.
peut-être juste tirer un peu les guides. Okay, c'est bon. Okay, so to be sure that. Okay, I think we should be able to. Oups, attention guiding, tu peux sortir.
Ouais.
Okay. So that's where we were the first time.
So what would your strategy be now? Would you put another RotaWire down or would you?
Yeah, that's the question. I don't think we went through the last lesion, which is very tight. It's not the more calcified, it's the tightest lesion. The more calcification was more in the left main in the proximal AD. Yeah, I think we could try with the RotaWire, and we'll see. On va,
Want a new one?
Ouais, un nouveau.
That one looks a little late.
Mais donne-moi un autre. Ouais, donne un floppy. We'll use a floppy RotaWire. Un guide à rotablateur floppy. On va checker l'ACT, ouais. OK, fais de la scopie. I would just look where the position of the. Yeah, so we're occlusive. What else to discuss? We could have go with another wire and use NC balloon or at high pressure to prepare the left main in the proximal AD.
So maybe for people who do a lot more lithotripsy, like me, why would you start with rotoblader? You know, when do you prefer to use rotoblader versus shockwave lithotripsy?
I don't think that, especially because of the profile, when you think it will be difficult to go through with any technology, then it's better to use the rollerblader. When there's a wire down, I think the rollerblader is 100 or 95.5%, 99.5% it will go through. Just faire un petit.
So your first step is to do rotoblader and then, yeah.
For me, it's more when you have a resistant lesion that you can use the shockwave.
So we're going to advance a new RotaWire floppy through our turnpike into the distal part of the septal.
Je vais t'enlever ça. Ouais. De lui mettre le bon torqueur.
Okay, I'm coming with the guide. Here comes the wire.
And it's going down.
A little bit of resistance here.
Ouais, c'est bon ça. Juste que je fasse un petit test, juste, mais on est occlusif, là, mais je pense que c'est.
Looks like we're heading in that lower branch.
Yeah.
It's not the same branch as before, but that seems to be as far as I can go.
Yeah, je pense que c'est correct.
So I'll let you take out the turnpike. I'm going to open.
Le rotablateur, il est-tu préparé, là, le 1.5?
So our strategy is to go back with another, with the 1.5 berth that we had the last time. We're on a new wire now. And we're out. Okay. Okay.
Bien mouillé, OK. On va la retester, hein, parce que...
The patient is still hemodynamically stable. There's been no issues. He's not having any pain. Just going to take our time and optimally prepare the lesion so we can get a good stent result in the end.
On va faire ça. OK. On va tester.
Any questions on the Slido? Okay, perfect. Well, we have George in the back, our fellow from Ecuador, who's going to be fielding the questions for us if you guys have any questions.
Moi, je l'ai eu une fois. Est-ce que je vais l'avoir 2 fois?
So our last ACT, are we due for another ACT? Going to do pour un autre ACT, là? Okay. In the meantime, I'm going to do an ACT.
Oui. Donc, je vais demander à Anita de le faire.
Ouais, on peut faire l'échange.
Et on tabasse. Ouais, une seringue, ouf.
Obviously, this patient is on Coumadin for mechanical mitral valve. And so the question becomes, you know, antiplatelet, we're going to discuss that in a bit, but antiplatelet agent, as Serge had said, probably aspirin while he's in hospital, but then go home really on only 2 agents. We try to avoid a triple therapy as much as we can. I can give it a go. Yeah.
Good.
Try to avoid triple therapy as much as we can, risk of bleeding, obviously. And so the optimal thing, I think, is 1 antiplatelet with Coumadin.
Fait que, OK, on va se mettre ici. On va la retester.
Okay. A little bit sticky. Get that wet. That's better.
Ouais, droit,
il faut
le
le
droit,
garder droit, là, parce
Ouais.
qu'il ne veut pas sortir.
Comme tout à l'heure.
Non, il sort pas. Là. Non. Yeah. Sorry, my wire doesn't seem to want to advance. It's going to keep it straight. Sometimes it gets stuck in the machine. Can't find its way.
Ici, des fois, c'est ici. Non, le frein. Non. Vas-y encore, non?
Non.
Non, c'est ici. Ah, ça. Ah oui, il est décroché. OK. Attends.
Now we got it.
Okay. Ouais, mais non, mais va le remettre, je vais le tirer.
OK.
Il était décroché. Attends, on va le retirer.
Ah, OK. And again.
That's good.
Ah, OK, ouais, c'est ça. Avancer l'autre affaire. Ça va sortir d'ici. Alrighty. Oh.
Ça sort pas, non?
Oui, ça sort, mais j'ai besoin de la faire pour connecter.
Vas-y.
I have the wire.
Tu veux-tu?
I don't have the other bit. Yeah, maybe our burr is not the. May have to change this one out.
Yeah. Yeah. Okay.
Yeah,
We'll do
because I have
that.
an issue here on the back.
Yeah.
Okay, so we're going to change the burr. Just a bit of a connection issue. We'll grab a new one.
Yeah. The position of the wire is very good. So because the burr was stuck in the LED, because we had to go back, go through, it may have damaged the last burr. So we'll go with another one, a 1.5 again.
Good. Oh, no.
Là, ouais.
Là, s'il te plaît.
Il se
Ah ouais, il
décroche.
se décroche. Well, I'm going to reconnect this. Okay, there we go.
Ouais, ou il glisse après le truc, ouais.
Et là,
Des fois, il glisse pas bien. OK, là, il est glissé. Tu tires, clic. OK.
All right, we're in business.
On recommence. Ça va toujours, M. Gosselin? OK.
Have you flushed that?
Ouais, ça flush, ouais.
Okay.
OK, donne 3000.
All right, here we go. For number 2. Hey, you want to test that? We're going to test the burr?
Oui.
Okay.
180 000, Ghislain.
Whenever you're ready. Okay, on.
OK, c'est bon. Hop. Okay. Well, push.
Remettre là, s'il te plaît.
Ah, tu l'as-tu mis? Ouais, il est-tu correct?
Ouais, attendez, on va juste. Tu le mettre parce que je le vois. Yeah.
Okay.
Perfect.
Et je push. Oups. Ouais, tirer un petit peu sur le guide, je pense. Okay.
Si tu me montrer plus de guiding, s'il te plaît. Bianca. Parfait. Yeah.
Ouais. Tirer encore un peu. OK.
Oh, tongue guiding. Guiders keep.
Ouais, il faut que tu tires encore un peu.
Okay.
La courbe, il ne fait pas la courbe. OK. OK. OK, we're in. OK. Donc, juste un petit test. Small test.
Yeah.
OK. OK, we can go.
Another test? Or?
No. There we are. Oh my God. So the chat is here. OK. Pousser le guide un peu, non? Tu ne peux pas pousser le guide, non?
No.
OK.
We put slow.
OK. OK. OK, so we went through the distal lesion, but it was again stuck when we pulled back. But I think it did what we want to do. Okay, test. Okay, we'll
Not
film.
really. Okay.
Oh.
Oh.
Okay, film.
Okay.
Okay. Okay, so we went through for sure. So I think that with the 1.5, we'll go with another wire, maybe with our BMW, another hydrophilic wire, and we'll go with balloon to prepare the left main in the proximality for stenting. So I think that the roller there has done the job. We passed through the very tight lesion just before the diagonal branch. So we should be able to go with balloon, NC balloon, or high pressure balloon. So we can pull back the roll later. And on va prendre, donne-moi donc un BM2 mais neuf. So I know that there's just a few minutes left. What we plan to do in the next minutes is to go with another BMW 2 and go with high pressure balloon to prepare the proximal LAD and the left main to receive a drug-eluting stent that we want to put just beside the ostium of the diagonal branch.
Okay. Oh.
There's no question. Eh? OK. Peut-être qu'il n'y a pas toujours des...
Okay, there you go. All right, so we're coming with our wire.
Test.
What would you want for your first balloon?
Yeah, I think we'll go with a small balloon,
Okay.
maybe a 2-0.
0-0. Do little canes.
Test.
Perfect.
Okay. Okay, so I'm coming through. Test encore. Okay.
We are past the worst of the lesion. Now we just got to get it back into our stuff going. There you go. Oh, almost there. Okay.
You see, it's free. Eh? Distally, I can move.
All right.
And
very nice. Yeah,
okay.
Perfect. All right, so we're going to start with our first balloon. It's a 2-0. Our last ACT was the dernier ACT, c'était quoi? Okay. Okay, juste rappelle-nous pour le prochain ACT.
So I like the position of the wire, very distal in a large branch. It's in the septal branch. So for sure, even if we use the ablator, we need preparation. And we want to see balloons that are well expanded before going with any stent. There's no way the stent will be better to crack the lesion than the balloon alone. So we really need to go with high pressure balloon or with anything that can really crack this lesion.
Yeah.
Sorry, we'll answer the question, but first you see how it's easy to go with the balloon. I don't want to go too much in the septal branch test. So maybe we can go. Attention.
Okay.
Je vais peut-être juste aller. On était en
spider?
Spider, ouais.
Okay, spider.
And I will put the balloon just distal to the osseum of the diagonal. But it was really easy to go through with the balloon. Okay, I'm test. Okay, so a little further. Test. Okay, perfect.
You're happy here?
Yes.
On. Okay. We're on a 14.
The balloon, it's only a 2, but it looks well deployed.
It does. It looks well expanded.
On peut aller maybe 16?
Sure. 16 atmospheres.
Okay, off.
Off at 20.
Like you can imagine, we'll go through all the LED. On.
On. Close. I'm at 16.
Again.
Opens very nicely.
Okay, off. And we'll do the proximal part. Okay, on.
On.
So what was the question again? Well, the circ is occluded, completely occluded with collaterals from the right. So it's like it's a proximal lady. The left main has no bifurcation for us.
Yeah.
So we don't need to do any
2.5 non compliant, s'il te plaît.
Any bifurcation work on the distal left main.
J'ai besoin de 2.5 non compliante par 15. OK.
OK, on va se remettre peut-être en 10-40.
And see, perfect.
Oh. Très bien. So we could have used IVUS at that point to size the proximal LED, attention, size the proximal LED and the left main. But I think that with balloon opening the artery, we will be able to see if it's 3 or 3.5. And then if our balloon will well expand, stent the lesion and do IVUS at the end to be sure that we have the right size of stent and a well deployed stent. In that kind of very calcified long lesion, going with IVUS first can be difficult. Very easy, you see?
Perfect.
And it's in
No resistance.
NC balloon.
You want to go in the other view, or you're
Yeah,
happy?
maybe.
Spider.
So I don't want to inflate a 2.5 balloon in the osseum of a septal branch. Eh? So I just want to put it before, so after the diagonal, but before the septal branch. Let's go get this. Okay, so more distal. C test. It's not.
Maybe a titch far.
Yeah, a little bit too far. But it shows us that we've got space to put the stent distal to the diagonal. Yes?
Good. Yeah.
Yeah, okay. Maybe like this. Okay.
Perfect. All right. On. Okay. I'm at 2.5 at 18 atmospheres. The non-compliant 2.5 by 15 balloon.
Okay, off. Here.
On. Same thing. 18 atmospheres. Opens nicely.
Okay, off. And then the proximal part. Just to be. Okay. Looks already large.
Already looks much better. Yeah. 18.
Okay, off. So another option would have been to go now try to go in the diagonal branch.
That 90-degree turn.
Yeah, but with the 90 degrees, I don't think that we cannot put the tip of a stent in that diagonal. I don't think it's the right way to do. Yes, d'abord. Okay, we'll film this one in the RAO afterwards. There's probably more work to do in the mid part, in the proximal LED.
Yeah, I think so. I think we'll see it better in the other view as well.
So maybe a trio if we go.
I think so. Trio non-compliant.
Yeah.
Come on, 3-0. Non-compliant, 3-0 15.
Okay. Yeah, you see?
Looks better, but more work to do, huh?
Yeah. So we'll inflate the balloon in that incidence, and we'll see what's the effect.
Especially to see I think the expansion of the balloon in this view is nice. Then we'll know if it's
Yeah.
being constrained by
Yeah.
that lower calcium. Parfait.
So we're following our initial plan. You know that in that kind of complex case, you always have to think during your case to change your mind. But we're stick with rollerblader 1.225, 1.5, and then non-compliant balloon to prepare the left main and the proximal lady. At that point, we could probably go with shockwave if we have problem, because it will go through the proximal lady. So it's a combination of different technology to really well prepare the lesion.
Yeah, and I think that's the most important point. Like before you put a stent, really make sure that you've well prepared the lesion, because if you haven't, your stent will not expand. Okay.
Again, really easy. Maybe we can see our diagonal here test.
Yeah, you can see that. Yeah.
Here. Okay. On.
On at 16, 18.
Okay. At that point, the distal lesion looks to be well cracked, but we'll look at the proximal LAD lesion.
Off.
Just a test to see those two plaque of calcium. Yeah, we're just
They're there, right there. Okay, on.
Oh, not so bad.
I'm at 18.
$20 maybe?
20 it is.
Okay, off.
And off.
Here.
On.
So I really think that the rollerblader,
18.
So it's better to go when it's a small lumen, very calcified. So for the calcium that is just behind the lumen, it's better to use a rollerblader. But for calcium that are more in depth, it's better to use, I think, the shockwave. But again, it's easy to go with some balloon.
So here, do you have a sense of what size stent you would use, or?
It's for the left main, it's probably 3.54.
Exactly.
The proximality would be 3.2. And then because we will use IVUS at the end. Okay, so we're
going to do an ACT.
Yeah.
Do you want another balloon, or you want to head to the stent?
I will look at the result.
Okay. ACT.
OK. Juste peut-être remplir le cathéter avant d'injecter. OK. OK, ciné. I would not go with a stent right away for sure.
No, I still think there's work left there.
Yeah.
I would take a 3.5 balloon.
3.5 NC.
Okay.
3.5.
12.5. Wait.
So now you look at the LAD just before the diagonal. Looks large. It looks almost 3.2, 3.5. And the flow in the diagonal is still very, very good. And you see how the diagonal is free of disease. It's amazing.
It is. It actually looks a little bit bigger to me.
Yeah.
So let's just say, sort of thinking ahead, if we're going to put this balloon in, we see the lesion is somewhat changed, but not 100% change. Is that, at what point would you say maybe we should do shockwave
Yeah,
before we
exactly.
put a, put the stent in there? Just got to keep that. Okay.
Okay, so we can go distal just before the diagonal test. A little bit more here. Okay, fine.
All right, on 3.5 by 15 non-compliant balloon at 16 atmospheres.
Well deployed.
Expands, yeah, very nicely.
Okay, off. And
Off.
And the real test is here.
Exactly. I'm going to back her up.
Un petit test juste pour voir si on est sur les deux.
Advance this a bit, yeah. Okay, on. I'm at 18. Oh, my balloon just broke.
Oh, okay. Another sign.
Yeah, so that's...
It may be the sign for the need of shockwave.
Yeah, my balloon just...
So first balloon, which is just went down. Okay, look to be sure that there's no dissection. After balloon that rupture, you can have problem with small hole. Okay, so I would go with the shockwave.
Right.
What do you think?
Yeah, I agree. 3.5 or 3?
3.5 maybe.
Okay, so we'll take a 3.5 shockwave balloon. C'est quoi les longueurs que tu vois, Ghislain?
C'est tout pareil, c'est 12.
C'est pareil, ouais. Mais c'est pas...
Il y a une longueur.
Ok, je pensais, ouais.
So,
have we got our ACT?
So we're already thinking of our stent. If we use a 3.5, it can be inflate at higher pressure in the left main and the proximal AD to get a diameter which will be near 4. Distal, or I would say LAD just proximal to the diagonal, will be more 3.2. That was I think we can estimate, but the IVUS at the end will help us to make the right decision for the right size.
We have a 3.5 by 12 shockwave lithotripsy balloon.
So it's not unusual to use two technology. You need to use the one that you start with for the better thing she's doing. So calcified lesion, long lesion, very small diameter, rotoblayer will go through. Shockwave will finish the job and go more deep to really have a crack the lesion.
Juste en cas, peux-tu donner un autre 2000 peut-être en externe? Yeah, I think this is a great example of how you need to have sometimes you need multiple techniques, and every technique has its niche and knowing when to use what. And you're obviously very experienced, so I was Serge's fellow not too long ago. So I'm still around, so he trained me well. Wait. Okay, we're just going to connect up.
Excuse me.
All right.
So the preparation of the shockwave is not so difficult. So you've got a couple of shots you can use. So after the first shot, you need to wait and then restart for another shot with the ultrasound shockwave.
Yeah, so we have a certain number of pulses at a time, and the machine will count those down for us. And the button will go from green to yellow and then back to green when we're ready to go. Okay, I gotta see my button. Okay. I'm still on yellow. C'est beau parce que c'est toujours jaune.
Faut que tu pèses sur le truc en bas.
Okay,
Voilà.
there we go. Now I'm in green.
Okay, so we'll see how it traveled through that calcium.
Did you want to just target this, I guess, at that lesion where we perforated the balloon right here? Exactly. Huh? Do you want to pass?
Yeah. So I would say easy without good support. It went through. So it means that our lumen is well open. It's only that there's two calcified. So maybe a test again.
All right.
Yeah.
I think you're good. Okay.
Okay, so 8 or 10 is enough for the inflation of the balloon. You want to be well opposed.
Okay, I'm at 10.
And you see the waist.
All right, I'm pushing.
Yeah.
So we're delivering the ultrasound energy. Okay, so we've got 10 pulses, and now we're going to take a little break. The balloon will come down.
Right.
Balloon down.
And we have 8 run. So again, inflation.
On. 10 atmospheres. And pulsing on.
Push this on. I think it's already better.
I think so too. Want to get our bang for our buck though. Balloon is down. It looks much better expanded.
Mm-hmm.
Didn't perforate.
Mm-hmm. Un petit test, Bianca, s'il vous plaît. Yeah, I'll push a little bit.
Exactly. Just get the tail end of that other one.
Okay.
Maybe just bring your guider in.
Ouais, c'est bon, ça.
Okay, I'm going to go up here. I am on at 10. Shockwave is on.
Yeah, the balloon doesn't look the same. Hey, you see the...
Okay. Off.
What do you think? Do you want to look? I can keep the shockwave here.
Let's do that. Let's do Cine and see what it looks like.
Pression. Okay, Cine. Bon.
Maybe a little more work to do.
Yeah. I think that we see the dissection, eh?
Yeah.
So it means that we cracked the lesion for sure.
Yeah.
Maybe in the upper part.
You want to just stent it?
I don't know, because I'm sure that the proximal, the left main, proximal AD are okay. We see the dissection. Montre-moi encore le ballon. It was
It's certainly well expanded, huh?
Okay, so we'll go with our stent.
Okay. We're going to bring the shockwave balloon back.
And now, decision about the stent.
We're going to keep that because if our stent, for whatever reason, fails to pass, I don't see why it would. But
okay, so 3.5.
3.5. We're going to.
Or
3.5 we can blow up to bigger if need be. We just need long.
Yeah. Yeah. Usually I use balloon to measure. Maybe not the shockwave balloon. Because I really want to be on the ostium of the left main, but not too far, past the diagonal. So it's probably very important to measure the exact length.
Can we measure it on QCA just to give us an idea? Okay. I'm guessing it's going to be about 32 to 34 millimeters.
Est-ce qu'on a comme ballon? On
a des
deux, on a de long un 2 cm. OK, on peut l'utiliser pour sizer aussi. Moi, là, ça va être encore plus safe. On en met un. So we'll put the 2 centimeters balloon in. And if it's 2 times, for sure, a 38 will be needed. If it's a little less than that, we use a 33, 32.
Mais ça, c'est un 2,15.
T'as-tu le 20?
Non, il veut 20 mm.
N'importe quoi, 20.
Il veut 20 mm de longueur.
On n'en a pas? Non, on n'en a pas? OK, on va prendre un. We'll use the 15. We use what we have on the table.
Okay, so we're going to use the 2015. We're going to see who's faster, us or our QCA.
Yeah, we'll have the QCA also. So, and then at that point, you can also do IVUS or OCT. And then you will have very precise measurement of length and diameter.
Right, just from the guider, exactly.
So I will go spider view to put my balloon exactly where I want distally, and then
27.
Yeah, but it's probably more than that. It's more proximal, I would say. Okay, what's going on? OK. Je suis pas très loin. OK, test.
C'est pas mal.
Ouais, mais un peu plus centré. Ouais. OK, un peu plus loin. Test. OK.
So that's way longer than 40.
Yeah. Okay, we'll film that.
15. Okay. It's going to be 40 almost.
So 15, 30. So 38 is the longest balloon. We also have 48, but 48 is too long.
Yeah.
So what we can do is use a 38 if we need a little bit more, a 12 or 8 in the left main, we'll do that with 2 stand. But that's 15. You add another 15, and then it's 38 could be good.
Yeah.
And you see, we can push a little bit more distal.
Yeah, we can cover the ostium and go a little bit further into the LED.
Yeah.
So then 38, s'il te plaît. The stent 35 by 38.
And we'll go in that view.
Can you do for an autre ACT, no? Okay, perfect.
And we'll have to prepare the IVUS for the next. Check our result. So maybe we can already discuss the antiplatelet therapy, even if the procedure is not over. Like I said, we can have a very short aspirin period, which can be anything between in hospital and you stop, or 2 weeks or a month. But with Coumadin and Plavix for a year, we don't want to have aspirin too much.
No, and I think in older patients, we have to be concerned about the risk of bleeding, obviously. I mean, there are some suggestions that you could combine aspirin and Coumadin for patients who've had embolic events with a mechanical valve. But obviously, with this stenting, I think we're better off with just Plavix and
and the INR, it will be between 2.5 and 3.5.
Correct.
It's not a 2.3.
Yeah, exactly.
And mitral valve also.
Yeah. Just gonna grab that. Okay, I have the wire. So we have a 3.538 stent. Let's see.
You see that we didn't ask for a specific company.
No.
We think that if you prepare well your lesion and your artery in 2023, there's a lot of stent that can go through. Almost all last generation stent can go through.
Parfait.
Okay.
Merci.
Okay, so
Okay.
I think we need to go in the other room. So it was a pleasure to be with you this afternoon. We'll finish the case. You'll be able to see the final result. But I hope you enjoyed the case.
Yes, thank you for joining us at the Montreal Heart Institute.
Bye-bye.